cyst is a swelling with or without inflammation at 4 o'clock, basically, and 8 o'clock position of the vulvar vestibule. It is responsible for the 2% of all the gynecological visits. So it's not that uncommon, but it is not that common also. So basically, what is a Bartholin cyst? It's a disease of reproductive age. And you can see, this is the inflammation, this is the swelling over the vulva on either the 4 o'clock position or like that. Now, the Bartholin gland basically is located beneath the fascia and the drain into the vestibule. It's a 0.5 centimeter in size. Then it's a mucus secreting gland, and the role of the Bartholin gland is basically the lubrication. So you can justify it. These are the glands and these are the ducts of the Bartholin cyst. When the ducts get obliterated or something, when this swelling increases and it leads to Bartholin cyst formation or like that. Now, what are the etiology and the symptoms of Bartholin cyst? Bartholin duct blockage can be caused by either trauma, sexual activity, childbirth or episiotomy, sometimes inflammation because of the unknown reason. And the patient comes with the symptoms, especially the painless, very fond. There is a swelling or the cyst, which is 1.15 centimeter size. It can be. Largest cyst can cause discomfort or patient can complain about the disparity. And the abscesses are painful. Sometimes this cyst turn into the abscesses and it is with or without the fever and the post-drainage. So the common pathogens and the antibiotics needed for the abscess and all the pathogens are E. coli, all the negative aerobes, Staphylococcus aureus, MRSA, standard vaginal flora organism, and in adolescents, chlamydia and gonorrhea are frequent ones. And they need antibiotics accordingly, especially if E. coli, the amoxicillin, syndamycin for the negative aerobes, and azithromycin, doxycycline, ciprofloxacin, all the trimethoprim, ceftriaxone, depending upon the pathogens are over there. So, but there are a problem. It's not a Bartholin cyst, it's a simple thing. There are some we have supposed to differentiate in between. There can be a cyst, inclusion cyst also. Then can be a sebaceous cyst. Sometimes there is a vulvar angiomyofibroblastoma, which is very uncommon, very unusual, and can be there. So we should be worried about endometriosis, especially on the episiotomy scar, can be a swelling over at the vulvar position, vulva with a is similar like a Bartholin cyst. Sometimes very unusual, that's again a perineal leiomyoma or the fibroid, and ischiorectal abscess. We should be differentiate about it. Folliculitis is not in the list, but the Gartner cyst is also one we keep in the point. And very rarely the adenocarcinoma of Bartholin gland. But we should know all the differential diagnosis points so that whenever we see the patient of Bartholin cyst, we should keep all these things in our mind to make up this thing. Bartholin gland carcinoma, very, very uncommon. Basically, 5% of all vulval cancer, mostly in the postmenopausal women. Average age is 57 years. It's a solid, non-tender lump. So it's another important. Now, how to treat it, either we should take a biopsy or what not to take the biopsy. So these are the indications for the pre-treatment biopsy. When the diagnosis is uncertain, we're not sure that this is of the Bartholin one, then we are supposed to take the biopsy. When there is an unusual pigmentation all around the vulva and making it something different, then we are supposed to take the biopsy. If there is an unduration, ulceration, and much bleeding for the long-standing bleeding or anything like that, at that time also we need to take a biopsy. Or that cyst or the gland, anything which is rapidly growing, that we need biopsy. And especially in the postmenopausal women having this thing, we should take the biopsy, and refractory ward over the vulva is another important one. Now, should we do the surgery for the Bartholin gland and cyst or we should not do it? Number one is incision and drainage, very simple one. Incision and drainage with a cavity closure. Incision and drainage with the insertion of word catheter. Incision and drainage with the insertion of Jacobi ring. We can do the marsupialization with the interrupted continuous sutures, whatever we needed. Aspiration and alcohol sclerotherapy is another one treatment part. Then incision and drainage and silver nitrate insertion. Sometimes the carbon dioxide laser therapy is also one of the very good treatment. Cryotherapy for the Bartholin gland and abscess and cyst is also there. And a total cyst excision is very, very important. Now, what should we do? The ideal treatment for the Bartholin cyst and abscess. Number one, it should be fast and safe. It should be performed on the outpatient under local anesthetic. No or uncommon recurrence, because there are chances of recurrence are more and patient can come again and again with a Bartholin cyst. It should be having the rapid healing. So incision and drainage, incision with or without closure, IND with stent or epithelialization the tract, then the word catheter or the Jacobi ring. These are two important things, and IND with a sclerosing therapy is another treatment, and it can be done under the local anesthesia. So this is IND with a word catheter, is a small catheter over there with a small balloon over there. We just inflate it, make the balloon this thing, OPD procedure, and can made up of latex. And an incision 3 mm is complete drainage, and the tip of the catheter is placed into the cavity and inflated 3 to 5 cc with a normal slide. Just keep it and put it over there, and cyst burns after the 24 hours, and catheter can be removed after 4 to 6 weeks. But it has got its advantage, but it has got its disadvantages also. And it is done under local anesthesia. Very little analgesia is required. But the catheter, keeping that catheter over there can lead to discomfort, and chances of recurrence are common. This is a similar IND with a Jacobi ring. Jacobi ring is nothing new. It's a small, in place of word catheter, Jacobi ring is used as a stent for epithelialization. This is the ring over there, and can simply made with a rubber catheter, small rubber catheter, put a thread inside, but it is less cumbersome than the word catheter. But advantages and disadvantages are same as the word catheter. So just these are the Jacobi ring, how to put it. Just give the incision, put it, drain this thing, and insert the ring like this and keep it over there. Just try both the threads over there and keep that rubber portion inside so that there is epithelialization and it will be treated. The most important is the marsupialization, incision in the vaginal entrance beyond the hymenal ring. This is another important point. Incision extend up to 1.5 to 3 centimeters. Interrupted sutures are placed circumferentially attached the cyst and the wall of fascia and skin. Review in 1 week to assess healing, and cyst bars after the 24 hours. But the post-operative antibiotics and analgesics are required, because we have given the incision in a bigger manner up to 1.5 to 3. So it needs time to heal, and just that's very, very important. And suture being used. So that's the reason. So just giving the vertical circumferential incision, open it, drain it, keep it open, and do the marsupialization by just retracting and putting the sutures. Now, ablative procedures, these are the latest one and which we can do it. Though it's a silver nitrate insertion, used to be an old one, but it is also ablation. So in the carbon dioxide laser therapy, another important point. Cryotherapy, if available, can be done. An active infection is a contraindicated to the ablative therapy. So if there is a chronic one and the patient is having no fever or nothing, at that time, all the ablative procedures can be done. Then aspiration and silver nitrate application and alcohol sclerotherapy is a novel method of management of Bartholin cyst and abscess. It's an alcohol sclerotherapy of the Bartholin cyst or the abscess is effective as silver nitrate application and associated with the less complication. It is ideal, safe, and attractive treatment modality for the gynecological diseases, and so many have done it. There's many studies of carbon dioxide laser treatment for the Bartholin cyst can be carried out safely in the outpatient with a minimum patient discomfort and high long-term cure. Then the excision is an indication of the recurrence, persistent deep infection. It can be given in a local anesthesia, regional anesthesia, or general anesthesia. Incision size depends upon the size of the cyst, and a careful dissection around the cyst until it completely enucleated without rupture. So it's another important point. Meticulous hemostasis is needed. Deep space to be obliterated with the absorbable sutures. And skin is closed with a 4-0 absorbable subcuticular suture. So Bartholin cyst excision can be done. It's a very simple, just give an incision, deliver it, the whole thing, remove the cyst, excision should be done, and the based area that they should have the correct approximation by suturing it and close the suturing line, the line of incision by 40 character. So the risk of Bartholin cyst excision are basically hemorrhage. It can lead to hematoma. It can lead to loss of vaginal lubrication. There can be a scarring, and there can be a chronic pain and dyspareunia and incomplete removal of the gland with a recurrence. We need some post-operative management, good antibiotics, good analgesics, set baths after 24 hours, and follow up after 1 week. But we have to evaluate the treatment of Bartholin cyst of the abscess in the systemic review over there. And they have found out the current evidence does not indicate difference in the rates of recurrence with a symptomatic cyst or abscess of the Bartholin when it's compared with the marsupialization. So whether you do the marsupialization or the complete removal of the cyst, there are chances, nothing to worry. Then the insertion of the word catheters offers other advantage, including the ability to undertake the procedure within office and avoidance of general anesthesia, reduction of the resource utilization, hospital beds, and usage of the operation theater. But still, this is not popular, and instead of word catheter, it's better to aspirate, or it's better to do the cyst excision or do the marsupialization are important. So in my experience, it was a great, so many cases we have seen this thing. The cysts are 30, abscesses are 48. Primary procedure marsupialization 70, excision and 8 recurrence over there, and complication or the recurrence in 3. Secondary hemorrhage, I think hardly in a case, and that's all. Thank you so much for patiently listening.